name's Cam McCarthy from the University of South Carolina, and I'm the chair of the TAC committee. And with me is Dr. Denise Cornelius from University of Mississippi Medical Center. It is our pleasure to introduce our keynote lecturer, David Harrison from Vanderbilt University.
How are you?
I'm doing well, thank you. We really appreciate your lecture this morning, and for me personally, I loved seeing the history you gave at the beginning of your lecture on immune mechanisms and hypertension, and then also how you've integrated that with your seminal contributions on oxidative stress and hypertension. Would you mind giving us a little bit more of a summary of your talk?
Sure. So I talked about a phenomenon that has actually been known for 50 years, and that is that immune cells have been seen in the tissues of people with hypertension, like in the kidney and the blood vessels, and in experimental models of hypertension since the 1970s, 1960s. And in the last number of years, we've had tools that have allowed us to study those in detail. And it's become apparent that these immune cells contribute not only to the elevation of blood pressure that occurs in experimental models, but also to the end organ damage that one sees. So, we think this is really important because end organ damage is really the reason we treat hypertension, right? To prevent the decline in kidney function and vascular function and dementia and heart failure. And, we're learning that these immune cells play a big role in those conditions.
Yeah, those findings you had on the vascular remodeling and aortic stiffening, like even after just 2 weeks of angiotensin, was amazing and really concerning for patients with hypertension.
Right. We found that just a short episode of hypertension causes persistent aortic stiffening that actually worsens over time, and this can lead to progressive immune activation and end organ damage. I should mention that this depends on the model, that there are certain mice strains that don't develop such aortic stiffening. The black 6 mouse, which we studied, does. And this is like people. There's some people that don't develop stiff aortas and other people that do. And there are probably genetic reasons and environmental reasons that control that.
It was very interesting. Again, that model was just that short period of hypertension. And that's similar to my studies in preeclampsia, where these women have hypertension during their pregnancy and it's resolved, but we know that they're at enhanced cardiovascular risk. Which brings me to one of the slides where you talked about the significant production of the ICGs in patients with lupus. And so I wanted to ask if there are any sex differences that you all saw in the production or the adduction of these ISGs that would probably explain the high prevalence of it in lupus, given that that's more prevalent in women.
So that's really interesting, Denise. We've mostly studied male mice because they are more prone to get hypertension than female mice. And so we have done that. We've recently started studying female mice, and they don't get the iso-LGs as much as the male mice do. And we think that that's because there's less oxidation that occurs in the antigen-presenting cells. Early on, we showed that in hypertension, these antigen-presenting cells have a big increase in superoxide production after you give the animal Ang2. We've always thought that the Ang2 or that the hypertension might affect the vasculature or the kidney or, intact organs, maybe the brain, and enhance ROS production in those tissues. But what we found is that there's actually increased ROS production in these immune cells, and that leads to oxidation of arachidonic acid and the formation of these isolevoglandins. That's in hypertension. All our studies in SLE have been in female mice. So SLE is different than hypertension in that regard, and that is that female SLE mice are prone to get hypertension, and our patients that we enrolled were 90% female with SLE in our study. So there's something about SLE that causes women to begin to form these isolevoglandins in their immune cells.
So towards the end of your presentation, you touched on the clinical therapeutics that have been used in animal studies and with humans. With all your significant mechanistic data that you've collected over the last few years, can you give any insight if there's anything in the pipeline that might be novel or coming out for patients with resistant hypertension?
So there's a nutraceutical that one can actually buy on Amazon called 2-hydroxybenzylamine. We've studied this for many years at Vanderbilt. It was developed at Vanderbilt, and it very effectively scavenges the isolevoglandins, and we can prevent all forms of experimental hypertension with that. We've given it to humans with metabolic syndrome and normal humans, and it seems to have no toxicity. We've used it in rat models of hypertension, and we have an ongoing clinical trial now for its use in rheumatoid arthritis that Michelle Ormseth is performing, and we would like to do this in people with lupus as well. So that's a drug that can be used. We have, considered the use of cytokine inhibitors like etanercept or related drugs, and those possibly could be used. The problem with inhibiting cytokines is that, number one, there's some side effects from that, right? You're left with some immune deficiency. And then the second problem is that you could have actually an increase in other cytokines when you inhibit one. And so you end up maybe not any better off. And of course, these agents are profoundly expensive. They cost thousands of dollars per month. So we tend to, not use those as much. The thing that I'm most excited about is that maybe lifestyle changes could affect these, So we've done some studies. We were interested in why even normal mice have some of these T cells that are isolevoglandin specific. That normally you would, if you're not ever exposed to an antigen, you would never have it, or you would have very few T cells that would respond to that antigen. It's only after antigenic exposure that you would have a proliferation of these cells, and they become memory cells that you can, keep in your tissues and then respond to the next time you see the antigen. But we saw, 2 or 3% of T cells that respond that seem to be specific for some of our isolevoglandin inductive peptides, even in normal mice. And we thought, well, maybe there's aspects of the microbiome that are priming. Maybe there's antigens that are seen in the microbiome that prime these things. And so we've collaborated with Balfour Sartar, who's the director of the Notobiotic facility at the University of North Carolina. And he's sent us mice and cells from his germ-free mice. They have 0 T cells that recognize these isolevoglandin adducts. So something about the microbiome is priming this. And the latest thing we found is that those antigen-presenting cells from those animals don't make any free radicals, and they don't make any isolevoglandins. So we think something about the microbiome is affecting these antigen-presenting cells to make free radicals, oxidize arachidonic acid, and make isolevoglandin. So the question arises, would the DASH diet, which we know lowers blood pressure, or would other, healthy diets reduce the presence of these things, and do unhealthy diets, promote their formation, perhaps through affecting the microbiome? That's a really important question that we plan to study.
Thank you, Dr. Harrison. Congratulations again on your keynote lecture.
Thank you so much.
Sincerely appreciate it.
Yeah.
We look forward to more of the science, and I did want to acknowledge that you have several trainees that have posters and presentations during this conference. So we look forward to seeing more of your work through their presentations. Thank you.